Well, good afternoon, everyone, and welcome to today's Epicenter Psychosis Speaker Series. I'm delighted to introduce our distinguished speaker today, Dr. Bernalyn Ruiz-Yu. Dr. Ruiz-Yu is a postdoctoral fellow at the CAPS program at UCLA, where she is working with individuals at clinical high risk for psychosis, both clinically, but also on a research perspective, looking at how to engage folks early on or at risk for psychosis and health behavior promotion, what we can do and how we can do it better. As we know that the physical health of individuals with serious mental illness is not only oftentimes a pretty significant concern, but more importantly is intricately tied with issues of recovery and mental health in general. The more we can strengthen our ability to address these things, the better supports we can be for people either at risk or early in the course of the illness. So it's very exciting to get to hear from an expert here today about how we can do that and do it better. As always, closed captioning is available by clicking on the CC button at the bottom of the screen. We'll have a Q&A session with Dr. Ruiz-Yu at the end of today's session, and questions for that should be sent to me in the chat, and I'll relay them to her when we get to the Q&A. And with that, let me turn things over to our distinguished speaker today, Dr. Bernalyn Ruiz-Yu.
Thank you, Dr. Brightboard. So I'm Dr. Bernalyn Ruiz-Yu. I use she, her pronouns. I'd like to start today with an acknowledgement of the land where this project was conducted. So we acknowledge that we are guests on the traditional, ancestral, and unceded territory of the Gabrielino Tongva people here in LA. So as Dr. Brightboard said, today I'll be presenting a summary of existing evidence on health behavior promotion, specifically for mental health in youth at clinical high risk for psychosis, and I'll go over some future directions for the field. So by the end of the presentation, my hope is that you will be able to summarize the state of the research in health promotion / lifestyle strategies for youth at risk for psychosis. We will identify strategies to promote and utilize with your patients, and we'll review future directions for this field. All right, and apologies, my computer is, okay. To get there, we will review the evidence on health behavior promotion research. We'll go over existing work that is being done to target these domains. I'll present some of our research that we're doing at UCLA at CAPS, which is the Center for the Assessment and Prevention of Prodromal States. The director is Dr. Carrie Bearden, and I'll present a little bit of some research that we've done in the aftercare program run by Keith Nectarline. We'll go over recommendations for practice, and we'll end with the future direction for the field. So let's jump in with our review. So first, I would like us all to define what do we mean when we say lifestyle strategies or health behaviors. And so you can just throw them in the chat or call them out. I see some experts in the audience, so we'll get some good definitions.
So folks in the audience are trying to unmute. Unfortunately, you can't, but please feel free to put things in the text.
Yeah, in the chat, yeah. All right, no worries. Perhaps they're not showing up for me, but I'll jump in, right? So we are referring to everyday habits that affect our physical health and mental health. There is a large field of lifestyle medicine that targets prevention and treatment for various physical illnesses. And there's been a wave of interest and recognition within psychiatry that everyday habits in the domains of physical activity, nutrition, substance use, sleep, and stress management can have an effect on mental health. So let's go over current guidelines. So at present, it is recommended that when someone presents with distress and attenuated or transient psychotic symptoms that are suggestive of a possible psychosis, or also if they present with distress and decline in social functioning and have a first-degree relative with a psychotic disorder, the recommendation first is that they be referred for evaluation by an expert. Then it's recommended that they be offered CBT with or without family intervention. And it's important to note that most youth who meet criteria for psychosis risk present with comorbid diagnoses and various other presenting problems. And so given that, guidelines suggest targeting the comorbid disorders or presenting problems and offering evidence-based treatment for those conditions as appropriate. So, such as targeting, depression, anxiety first. Guidelines also recommend offering social, educational, or vocational interventions as needed to target functioning, such as social skills training, or some colleagues, Michelle Friedman-Yakubian and Michelle West, have developed they call it INVEST. It's a vocational school work coaching program to target functioning. And lastly, if these interventions do not work, or if the individual presents with worsening symptoms, using low-dose second-generation antipsychotics to stabilize symptoms can be used. I want to be very clear here that this is not recommended as a method of prevention in our CHR youth. This is to stabilize psychotic symptoms. Okay, so as we see at this time, targeting health behaviors is not a primary recommendation. And so today we'll go over the evidence on how health behaviors play a role in psychosis risk and outcomes for CHR youth, and discuss possible recommendations. All right, so to begin looking at the evidence on health behaviors, one of the leading researchers in this field, Dr. Joseph Firth, conducted a meta-review looking at the evidence present for physical activity, tobacco smoking, diet, and sleep, and their impact on risk and outcomes for various mental disorders. And so to describe this a little bit, the dashed lines indicate evidence for protective benefits. The solid lines indicate evidence for efficacy in treatment. And the double solid line indicates convergent evidence from various studies and RCTs. And then the treble solid line indicates the best evidence. So what's going on here? So overall, they conclude that there is strong evidence for physical activity as prevention and treatment, in particular, that exercise interventions may be effective adjunctive treatments for depression, anxiety, stress-related disorders, psychotic disorders, and ADHD. That there is increasingly strong evidence that smoking tobacco is a significant risk factor for various psychiatric disorders. They conclude that poor sleep is a risk factor for mental illness, but more research is needed to understand the bidirectional effects. That the effect of diet on mental illness is less clear, but we see that healthy dietary patterns are associated with reduced risk for depression, but no association with other mental illnesses was established. So diving a little bit deeper now, so that was generally mental health across the board. Now diving deeper into clinical high risk, specifically what we know about lifestyle factors in psychosis risk. Here we see this forest plot of a meta-analysis conducted by Brockmeyer et al., where we see the studies that they included here on the left and their individual odds ratios. And so you can see that they included 5 unique cohort studies, and we see that the combined odds ratio of 0.72 with a significant p-value, which indicates that youth who engage in higher levels of physical activity, the authors conclude, have a 27% decreased risk of incident psychosis. However, in this same study, when they go on to include studies that adjusted for confounders like age, sex, parental mental health, BMI, they saw that this effect went away. And so the authors of this study go on to conclude that evidence suggests that physical activity may not be related to the onset of psychosis, and that we need more research to look at confounding factors. So overall, we need larger cohort studies to make conclusive statements of the role physical activity plays in actually developing psychosis. but there is potential for this potential protective effect. One theory I've seen suggested is that in order for physical activity to have those positive effects on health, the behavior needs to be consistent. So maybe there's some like compounding positive effect of habitual exercise that maybe our studies aren't capturing. And so, of course, I'm sure we can all attest to physical activity having some positive effects. I know when I get to run in the morning, I think clearer, I'm more energized, more motivated, just my day goes better. And so in CHR youth, we see sort of these similar things. While, as we saw in the previous slides, that the evidence that physical activity can reduce risk of conversion to a psychotic disorder is inconclusive, there are many other positive benefits of engaging in physical activity. And again, I want to really emphasize that it's important to remember that most CHR youth who present to our clinics have comorbid diagnoses or present with other distressing symptoms. Like they often have difficulties in social settings, difficulties with concentration, low mood. And so in this population, various research studies, across various research studies, there's been evidence that physical activity improves physical fitness, cardiometabolic risk factors, which we know are important long-term for those who may go on to develop a psychotic disorder. It improves functioning, comorbid psychiatric disorders, again, like depression, anxiety, cognitive functioning, positive and negative symptoms, and quality of life. All right, so that's physical activity. So now moving on to what we know about substance use, in particular tobacco use. Studies have demonstrated that even that when compared to non-smokers, smokers have a heightened risk of developing a psychotic disorder. And so this forest plot here shows that the risk ratio of developing a new psychotic disorder in daily smokers compared to non-smokers is about twofold. And in this study, they also showed that those who smoked daily developed a psychotic illness at an earlier age than non-smokers. Those with psychosis started smoking at a non-significantly earlier age than did healthy controls. And this I want to highlight for the CHR population in particular. This is, sort of important. We're thinking about adolescents, and this could be an important and a good time to target this particular health behavior. In this study, the authors go on to conclude that the effect is modest and suggest that smoking is associated with the onset of psychosis, and that we need more research to account for other confounding variables. There we go. Okay, so now looking at substance use, particularly cannabis use, there's a large body of research on the association between cannabis use and psychotic disorders. Focusing on CHR populations, we see lifetime use is reported to be around 48.7%, current use 25.8%, daily use 23.5%, and cannabis use disorder is estimated to be about 15% in this population. All right. In the most recent meta-analysis of studies done in clinical high-risk youth, here by Ferris et al., they conclude that the pooled relative risk slightly increased the risk of transitioning to psychotic disorders. However, this was not statistically significant, which you can see here. They also point out that when they removed this study up at the top that had the tenfold risk, their overall results stayed the same. And notably also that study was quite small. And other researchers have concluded that the evidence is strong enough to warrant a public health warning that cannabis use can increase risk of developing a psychotic disorder. We need more research to clarify the magnitude of this effect and also to understand the effect or differences across different strains of cannabis and identify groups that are especially vulnerable. I think especially in this changing landscape of cannabis production and use in our country. And at UCLA, in the CAPS program, we have some colleagues, Carolyn Amir and Simon Kepler, are working on developing a cannabis use scale for use in CHR youth, which we hope will give us better data collection methods for this population. All right, and so now moving on to sleep, what the evidence shows. Here we, oops, oh yeah, this is evidence from a study conducted in CHR youth in New York City. And the youth in this study reported significantly more sleep disturbances than healthy controls. And sleep disturbances were associated with greater positive and negative symptoms and worse overall functioning. And so let's look a little bit closer. So here's the same study. On the top, we see the items and their associated constructs, and the variables of interest on the left. And so specifically, we see that sleep pattern disruption and day-night reversal are associated with total positive symptoms. Daytime fatigue, sleep pattern disruption, and day-night reversal were associated with negative symptoms. Sleep pattern disruption was associated with general functioning. So then moving a little bit forward, the most recent study of sleep disturbances in clinical high-risk youth done by Zaks et al. Using the Naples 3 data, so pretty new. We see this was published in 2022, so some new data coming in. They looked at whether sleep disturbances predict conversion to psychosis. And so in this figure, we see that sleep disturbance was associated with total symptoms, positive symptoms, negative symptoms, disorganized symptoms, and general symptoms. But there was no group by sleep interaction, suggesting that this association between sleep and symptoms were the same between those who went on to develop a psychotic disorder and those who did not. What this study did that was pretty interesting and novel, gives us some new data, some new information. They go on to do really fancy analysis to look at the directional effects. And what they showed was that baseline sleep was associated with total symptoms, positive symptoms, negative symptoms, and general symptoms at 2 months. And what's important to note here is that only the effect between general symptoms and sleep was significant in both directions. So I think we can start to maybe answer one of the questions that was presented at the beginning of the presentation, looking at the directional effect. In CHR specifically, we have some evidence of the direction of this relationship, that sleep may predict CHR symptoms, but not the other way around. And so I think this is very exciting and points at like a really, great target for intervention. Yes. All right, so thinking about diet, so there's been very limited research done in the realm of nutrition and diet, specifically in psychosis risk. So pulling from Firth et al. In 2020, in the review that we talked about in the beginning, they identified 10 meta-analyses that looked at the effect of dietary patterns on depression. They concluded that healthy dietary patterns were associated with significantly reduced risk of depression, and the same for healthy food groups. And interestingly, there was no findings for the reverse, so unhealthy diet and risk for depression. They did not find that to be significant. And so this is an area where we need significantly more research, specifically, in thinking about our psychosis risk populations or our youth that are at risk of developing a psychotic disorder. So there was this early study that looked at omega-3 supplementation, and in the early study, they showed that omega-3 intake was significantly associated with reduced symptoms and improved functioning. However, that study did not replicate. And so we see the results here of the replication study by Magori et al. In 2017. And so you can see here that the rate of transitioning to psychosis between those in the omega-3 group and those in the placebo group, their estimated 6-month transition rate was 5.1% in the control group and 6.7% in the omega-3 group. At 12 months, those rates were 11.2 in controls and 11.5 in the omega-3 group. So we see no significant difference. And then in 2020, there was a review that was published of omega-3 fatty acid intake in clinical high-risk youth. And they combined data from 4 studies, including the NeuroPro study from the previous slide. And in this study, they go on to conclude that there is a positive correlation between dietary omega-3 fatty acid intake on functional status, and particularly at EPA versus DHA. So when we're making our recommendations, it seems like the omega-3 EPA has more benefits. And they conclude that we need more research findings, and that findings remain conflicting. Overall, though, I think we can say that having a whole food diet and maybe consuming omega-3 rich foods may improve symptoms and functioning. All right, so given all that evidence about what we know about different health behaviors and how they impact psychosis risk, symptoms, and outcomes, what are people doing? So there's been a lot of work done on exercise programs, with most targeting depression in first episode. Looking at prevention, specifically to my knowledge, I've only come across one study that has attempted to target all of these behaviors. And so we'll go over that study. This was a study done in Taiwan by Tsai et al. In 2021. They conducted a randomized trial of a lifestyle program for young adults who met criteria for at-risk mental state, sort of the equivalent of like CHR. In their intervention and control groups, they included 46 young adults who met ARMS criteria. Their intervention included 3 sessions every 6 weeks, 60 to 90 minutes, where they covered exercise, stress management, nutrition, health responsibility, which they defined as paying attention to your health condition and seeking professional assistance if needed, and attending the health lesson. Okay, so what did they find? Comparing the control and intervention group pre and post intervention, they found significant improvements for those who participated in the intervention group on overall health promotion, lifestyle, so engaging in those healthy lifestyle behaviors, nutrition, overall quality of life, and within that, the psychological domain of quality of life, and state and trait anxiety. Okay, so the evidence we've reviewed, and I think given the positive results from the Tsai study, point to a very positive potential of an intervention targeting health behaviors in clinical high-risk youth. If we could sort of compound the positive effects across the various health behaviors, I think we could imagine some sort of additive protective effect for CHR youth. Whether that's actually decreasing risk for psychosis, great, but ultimately I think improving other distressing symptoms would be incredibly beneficial for this population. So at UCLA, in the CAPS program, which again is the Center for the Assessment of Prodromal and Prevention of Prodromal States, we've looked at some of these health behaviors, and I'm going to present some new data on physical activity and report on some feasibility of doing health behavior promotion interventions. We collected data across 8 sites participating in a randomized trial of family therapy led by David Miklowitz. So this is a national sample. We had a sample of 61 participants with an average age of 16, half male, half female sex assigned at birth, and varying gender identities. And importantly, when we look at race and ethnicity, a large proportion of our population is white. And then the next most reported ethnicity is multiracial and Asian American. And the mean years of education in parents in this sample was about 15. So, pretty well educated group of parents. Household income appeared to be left skewed, with almost half making $100,000 a year and above. 100,000, yes. So, pretty well-resourced group. In this sample, so this sample also reported having minor or no physical health problems, which I think is great and suggests that this group is well suited to promote lifestyle strategies. And here we see the average role and social functioning in this sample was about a 6, which represents moderate impairment across these two domains. And positive symptom rating was 11. The average was 11, with scores ranging from 0 to 20. All right, so let's see what we found. So we administered a physical activity measure previously published and developed for use with CHR Youth by Dayton and Addington. And we saw that the most commonly reported physical activity was walking, followed by exercising in public spaces, and 6% of youth reported not engaging in any physical activity. I think what's interesting is that only 10% reported participating in team sports. According to the CDC, about half of teens participate in team sports in the general population. So, much less participation in team sports in our CHR youth. So then we asked them about the frequency that they engage in moderately vigorous physical activity. So we asked them, in a typical week, how many times do you engage in physical activity that is hard enough and intense enough that it makes you sweat or breathe hard? Combining these blue and orange slices of this pie, about 62% of youth engage in physical activity at least 2 to 3 times a week at moderate intensity. So then to capture how much of the time they're spending in exercise, we asked, how long do you usually spend doing physical activity at one time? So in this sample, time spent exercising varied, but pretty good. A majority spend at least 45 minutes. So, 45 minutes, 2 to 3 times a week. That's not too bad. And so to gauge the intensity at which they are exercising, we asked, when you engage in physical activity, how often do you find you have to work so hard that you are sweating and your heart beats faster? And youth report about 70% of the time, so again, combining the orange and blue, that they're engaging in moderately vigorous physical activity. And I think this is a really important piece of information, as previous research has shown that the most beneficial physical activity is when you're engaging in moderate to vigorous intensity to have some positive effects. And let's see. Okay, so we wanted to get a better picture of these behaviors. So looking a little bit deeper in the data, we found that the frequency of physical activity was associated with better social functioning, which is interesting to me. And I guess may suggest that those who are less ill have better functioning or are more active as well. We also saw that there was no association between frequency of physical activity and positive symptom severity or rule functioning, which to me is encouraging and may suggest that positive symptoms in this population may not be getting in the way of participating in physical activity. So that's not what's holding them back. Okay. So given the evidence, we were also curious to see if youth would be interested in learning health behavior strategies. The question we asked was, how interested would you be in participating in a group to learn healthy living tips? Overall, more than half of participants reported some interest in health behavior strategies, which I find is encouraging. And so taking a closer look at who is interested, being interested in lifestyle strategies was not associated with sex assigned at birth, age, parental education, positive symptoms, or physical health conditions. So again, encouraging that generally these youth are interested. And we saw that there was this trend towards an association between interest and household income. But again, our sample was very high income families. Okay, so to review so far what we've gone over, we've established that health behaviors, including physical activity, sleep, substance use, and diet with less evidence can have an effect on mental health in CHR youth. However, no evidence to suggest an association with actual transition to psychosis. But again, important to note that these youth present with various other symptoms, and so only 20 to 30% actually go on to develop psychosis. So that's not the fact that it doesn't affect that doesn't make it not a great target. So similar to previous research that's been published at CAPS, we saw that CHR youth engage in moderate levels of physical activity, about 45 minutes, 2 to 3 times a week, and 70% of the time that's at a moderate intensity. So that's not bad, but it still doesn't meet the recommended 1 hour a day of moderately vigorous physical activity for teens that's recommended by the CDC. And they engage in lower rates of team sports than the general population, which is not surprising, right? Of course, given the negative symptoms and social functioning deficits in CHR youth. One thing I'm interested in looking more into is, which we didn't have data on, was school attendance and whether or not that is related to their participation in physical activity. Some helpful things in this national sample, about half of youth said they'd be interested in learning health behaviors to improve their mental health. And that's great. But I'm sure, as has been the case, and we all know that helping people engage in more health promoting activities is not easy. And within our CHR youth, there's our added challenges. When someone's experiencing negative symptoms, anxiety, depression, this can influence motivation. And so what can we do? So I'm going to present some data, some findings from the aftercare research program, which is actually a first episode program, but we wanted to target motivation and participation in exercise. So Keith Nectarline is leading a randomized trial looking at the effects of cognitive training versus cognitive training plus exercise to encourage participation in exercise. We used a digital messaging program, which we'll go over in the next slide. But to give you a sense of the sample in this study, we included 53 young adults who met criteria for first episode. The mean age was about 23, and most were male sex assigned at birth and had an average education of 13 years. In this study, they completed, or they were enrolled to complete 4 sessions of cognitive training per week and 2 sessions of exercise in the clinic or in the group. And they were encouraged to complete exercise at home. And so the aim of the digital intervention was to increase participation in exercise, with the goal being 150 minutes a week of moderate aerobic activity. All right, so let's see. We used a web platform called Chorus, which was developed by Armin Arivian at UCLA. We set up individualized messages to the patient to encourage participation in exercise. So for example, the participant might get the message, here's your reminder to lace up your sneakers and head out for a jog. Remember to text a reply to your exercise coach, such as, yes, I'm exercising today, or no, I could use some motivation. So if they replied yes, they would get, bravo, your dedication is really paying off. Or if they replied no, they'd get, you can do anything. Repeat this to yourself 10 times as you lace up your sneakers. And so all of these messages were personalized to the individual. So sometimes, so oftentimes what we would say to them was something that they would find motivating, or it was personalized to you have time in the evening or you have time in the morning. And we tried to personalize these. Okay, so what did we find? We found that baseline motivation for exercise and participating in the messaging program both were associated with group exercise attendance. We also saw that those who participated in the messaging intervention completed more at-home exercise compared to those who did not. The total number and frequency of text message reminders were not associated with exercise completed, and the number and frequency of messages was not associated with at-home exercise. So overall, there was some effect in those that participated in the chorus intervention or the messaging intervention. However, this had more to do with their intrinsic motivation to exercise, and interestingly also their intrinsic motivation to participate in a program to boost their engagement and motivation. So at CAPS, We are recruiting and collecting data for a feasibility study of a health behavior promotion group. We are recruiting 12 participants to participate in a 12-week health behavior promotion group. We have designed 8 modules that cover psychoeducation, goal setting, physical activity, sleep, substance use, nutrition, and stress management. We are including youth 13 to 17 who meet CHR criteria on the SIPs or the psychs. And we are excluding those who meet criteria for a lifetime psychotic disorder, have impaired intellectual functioning, have a neurological disorder, traumatic brain injury, or a substance use disorder, or substance use that makes the CHR diagnosis ambiguous. So our aim for the group is to be evidence-based and share what we know about how everyday lifestyle factors can influence mental health. It's designed using a motivational interviewing strategies. So being thoughtful about engaging, focusing, evoking, and planning within the group, and being person-centered. And some things we are mindful about is the risk of being minimizing, so not being minimizing about their experience. As I can imagine, if we were to tell someone with CHR symptoms to just eat better, that might come off oversimplifying and minimizing. We are aware of the systemic challenges of access to green space, access to healthy food. So we want to be person-centered and meet teens where they're at and what is possible. And so another thing that's important based on the research is to increase intrinsic motivation, which research has demonstrated is best done through fostering feelings of autonomy, competence, social relatedness, and well-being. These are the goals of the group and what we think would be helpful. So given everything, what can we recommend at this time? So in summary, we see that physical activity can decrease symptoms and improve functioning in CHR youth, and it may decrease risk of developing psychosis, but we need more research to be able to account for confounding variables. However, there are numerous other benefits that result from engaging in physical activity. For substance use, we see that there is a modest effect, and some have suggested that we should look into the causal role of tobacco use in psychosis, highlighting a really promising area for research. Cannabis use may increase the risk of transitioning to psychosis, but we haven't seen significant effects in CHR populations. There may be issues in the data collection, for which some folks in our group are working on developing some better measures. With regard to sleep, sleep may predict CHR symptoms, but we don't see it go the other way around. And sleep does not predict transition to a psychotic disorder. For nutrition, overall, we can say that having a whole food diet and maybe eating more omega-3 rich foods can improve symptoms and functioning. Okay, so our recommendations at this time, we recommend explicit recommendation of promotion of physical activity for clinical high-risk youth. Other researchers have called for physical activity promotion initiatives through schools where youth do spend most of their time. At CAPS, our approach is typically, of course, we will recommend physical activity or continued participation in physical activity in a way that is motivating and interesting to the youth. Right, we're only going to participate in this if they find it fun. If not, less likely they're going to participate. And so sometimes this doesn't, this has involved getting parents involved in engaging their youth in physical activity. Right, and so I think a major challenge is that it's one thing to put the recommendation, on your recommendations list and then hand it to the family, but I don't think we can all imagine, right, that's not really going to be very effective. And so we need to figure out how to have a conversation with these adolescents that is person-centered and takes into consideration their various presenting symptoms and their environment. And I think we do have a duty and a responsibility to communicate this evidence to these youth and families, as you could imagine it could reduce the need for psychiatric medications or reduce the dosage needed of those medications. This could also aid in the positive effects of psychotherapy. So, and So for example, from Keith Nectarline's current research that we just presented, we went over, um, they're seeing this synergistic effect of participating in exercise and cognitive training at the same time. So I think we can imagine this translating to psychotherapy as well. And where possible, providing supervised exercise interventions that include moderate to vigorous activity should be provided through mental health services or through referrals. And I think at least encouraging moderate to vigorous aerobic activity several times a week. Given the evidence on sleep, I think sleep is a great intervention target, as it seems to be that poor sleep can lead to worse symptoms. There's good evidence that CBTI significantly reduces the severity of hallucinations and paranoia, making this a quick, or relatively quick and effective offering for CHR youth. One thing we also see is the potential for digital interventions and digital tools to be used to improve health behaviors. Right, of course, youth spend a lot of time engaging with digital technologies, and these tools are getting better and better. And based on the results I presented earlier, these kinds of interventions or strategies work best when they are individualized and are best suited for those who are motivated to use these types of interventions. As usual, I really want to emphasize that our approach to doing lifestyle interventions and health behavior promotion, it needs to be patient-centered and individualized to fit that individual person. And so thinking about future directions for our research, there need to be more and larger studies to account for confounding factors. We have some good evidence. We need to be able to better account for confounding variables and to allow us to look at the direction of these relationships. I think we would do well with using novel data collection strategies. So for example, using physical activity sensors or monitoring sleep and sleep quality. We really need to identify ways that we can increase health behaviors. So for example, I think some questions I have, are people more likely to engage in health behaviors if, this is promoted through the clinic? Should the parents be involved? We already know that trainers and coaches should provide exercise interventions. We know that that really improves engagement and exercise. But can peer providers or non-clinical staff encourage health behaviors in youth? That's a question I'm very curious about. And I think a huge area of need, as we went over, a huge area of need is looking at the effect of nutrition on symptoms in adolescence. Okay, and thinking about the future directions for treatment and interventions, so building on the evidence from Tsai et al., I think we need to develop interventions that target health behaviors and assess how these do or do not affect symptoms and experience of patients. Assessing the acceptability from a qualitative standpoint would also be very valuable to allow youth to provide thorough feedback on these programs. Of particular importance in our psychosis early intervention efforts is to make our treatments more accessible. So we've done really well in creating really awesome research programs. We're able to see patients, we've seen patients come from far away. I've been at CAPS, I've also been at the CEDAR program in Boston, and in both places we've seen people come from very far away to access these novel treatments, these novel services. And, of course, one possibility is continuing to use digital intervention strategies. We saw with COVID, everybody moved entirely to Zoom and patients remained involved. In LA, I could say at least, we've seen patients that would otherwise have to drive like 2 hours to be seen, and we've been able to see them consistently. I do think, though, that we need to be mindful of this particular population. From my experience, there is value from seeing patients in person that cannot be replicated through Zoom. So periodic check-ins with patients in person as is feasible to the patient are recommended. You can look at a publication by Joseph DeLuca on using telehealth with CHR youth for specific guidelines. They provide some a good thorough reviewing guidelines. There are some groups who are developing novel ways of using virtual reality to deliver psychosocial treatments, which is showing some promise. Okay, so overall, given the evidence and potential beneficial physical and mental health effects and the lack of risk and side effects. We believe that CHR youth and early intervention programs should really all be receiving psychoeducation and health behavior promotion upon entry into our clinics. At CAPS, we're working on developing an intervention to target health behaviors with our goal of increasing psychoeducation about symptoms and how lifestyle factors can influence mental health symptoms, and to increase motivation for engaging in health promoting behaviors. And again, I want to emphasize that these problems are, we do not want to be minimizing. We know that these problems are large and systemic, and there are, problems around access to healthy food and healthy, green space to actually exercise. So we don't want to be minimizing, and I think these are this is a huge challenge, and so we're working on this small piece of like how do we actually work with youth, and can we increase these health behavior promotion behaviors. All right, so it's been great presenting, and I hope that we can all move forward in advancing care for youth at risk for psychosis. I know that's my ultimate goal, and I'm sure it's everybody's goal here.
Well, Dr. Ruiz-Yu, thank you for a wonderful presentation here today. I see the applause coming in from the group here. So why don't we switch over to our Q&A? We've already had a few questions come in, but as a reminder, questions for Dr. Ruiz-Yu should be sent to me in the chat. First question we have is, if you have advice about strategies for overcoming clinical high-risk associated social barriers or symptoms for participating in exercise groups.
Oh, that's a great question. And that's what we're hoping to try to figure out with our health behavior promotion group. I mean, I think thinking about my practice, my clinical practice, what I've done and what I've seen help is like getting the family involved. If there's if parents are able to say to the teen, we're going to go on a walk this evening and let's do that together. That's been one thing that I have found to be effective. We're really working on that's our challenges where we want to address that. And I think also based on the research, there's some research on like intrinsic motivation really seems to be very important here. And we also saw that with like our messaging study, where it really comes down to like intrinsic motivation. And so then like, how do you increase that? And so I think having feelings of like autonomy was a research-based strategy of like how you actually increase intrinsic motivation. So that would be something to think about as well.
The next question that came in is, what are your thoughts about video game-based exercise programs like Beat Fit or Dance Dance Revolution?
Oh, that's a great question. That's a great question. Yeah, I love that. I think thinking about, but what this comes to mind for me is like there's some folks I think over at MGH who are looking at using virtual reality to engage in groups, and I think we could imagine, right, the utility of also like using these video game based exercises with teens. I mean, I think sure. I think go for it. I think that's, if that gets them to be active and they enjoy it. I think that's another really important piece, is that they have to enjoy what they're doing. I'm not going to tell a teenager to go run if they hate running. It's not going to work. So if that's what they enjoy, I think, yeah, let's do it.
The next question we have is, are there effective strategies to help youth at clinical high risk for psychosis stop or reduce vaping?
Oh my gosh, that is a whole field of research, and I'm not going to pretend to be an expert in that. But I think our go-to at CAPS, our focus is harm reduction, right? So using those harm reduction strategies of, how can we, can you find a replacement behavior? Can you do this, a little bit less? What are you using? What kinds of oils are you putting in your vape, and having a conversation about, right, like we know that if we could reduce the THC content, do more CBD, or I don't know if that's exactly what they're using, maybe they're talking about nicotine, but if the concern is cannabis use, having a conversation about what do you know about the oils that you're using. I would just focus on harm reduction, have an explicit conversation around what they're using.
Great. The next question is, in the aftercare study, could
Mhm.
you say more about how you personalize the messages for each
Mhm.
individual? How did you determine what would work best for a given person?
Yeah, yeah. Um, yes, great question. So the groups, they also have this like weekly check-in with coaches, and where they talk about like how things are going. And so in those meetings where like the exercise trainer, she's also present. Um, they talk about barriers, like uh, did you do your homework? Which their homework is like to exercise at home. And they'll talk about barriers, getting in the way for you. And so they'll personalize the strategies around that. Maybe, I don't know. Let's see, trying to think of an example from our group. Um, let's see. So yeah, so for example, some uh, young adults there would have some challenges around you know, actually getting up on time to complete their exercise. And we know that that can be a big challenge with our population. And so we might personalize the messages by, encouraging them to get up, or, then having some follow-up messages to say, pick a time that's going to work for you. Um, so yeah, we'd have check-ins with them weekly, see what's working, see what's not working, what's getting in the way, um, and what's going to be motivating to them.
The next question is, at CAPS, does any of your work attempt to address the health behaviors and habits of an entire household or family, more than just utilizing the family to support the individual's behavioral change?
Wow, that's a fantastic question. I mean, to be completely honest, I haven't thought about that, and I'm not aware of work done in that realm, but it does make me think that's something I need to think about. It's something I should look into. So if you have any, I don't know, any suggestions, any resources that you want to point me to, yeah, email me. I'd love to learn more about that. I haven't thought about that. Oh, I see a hand up. Oh, you're muted, Dr. Brightboard.
I don't think we have it set up for other people to unmute,
Yeah.
but feel free to put comments in the chat. Apologies about that. Um, Maybe we'll wait to see if that one comes in and go to the next question, which is, um, do you have a hypothesis for why physical activity among individuals at clinical high risk was associated with social functioning, but not with role functioning?
Mm-hmm. I don't actually. This is like brand new data that we're looking at, but yeah, it's a good question. I guess off the top of my head, social function. I mean, I could imagine if they're social functioning, if you're somebody who, um, I think what I had said in the slides was like, perhaps these people are just those who are less ill, who have better social functioning. And so they're better able to engage in physical activity. Um, Something I definitely want to think about. I don't think I have that fully figured out.
So coming back to the previous question, I got some more details in the chat.
Yeah.
The question or the reason for asking from the question asker was because in New York, where the person's at, they have multi-generational immigrant families
Oh
who
yeah.
operate off different definitions of health. And I'm wondering maybe, if I'm getting the question wrong here, please feel free to let me know. But I'm wondering if you can comment a little bit about maybe thoughts you'd have about how you might address something like that here, if there are different views about health in a family.
Oh my gosh. Yeah. Wow. Yeah. That, I mean, I think, okay, like let's imagine if that was, you know, my client presenting, what I might do is, I mean, I think I always kind of go to like person centered, you want to be culturally responsive. And so understanding from their perspective, what do they think is what is their definition of health? Because you say they have different ideas of what health is, and so what is that? I think always going, always using, uh, using their goals, and getting them on the same page, or identifying what their goals are and how maybe their behaviors are getting in the way of reaching those goals. I would, yeah, just use your therapeutic skills around goals, being person centered, understanding what their definitions are, and working with them collaboratively. That would be my approach. I could imagine if I had a client show up and that was the challenge.
Great. Well, that brings us to the end of our questions that we have submitted. So I'd like to thank you again, Dr. Ruiz-Yu, for a wonderful presentation here today. And
Thank you.
yeah, thanks for everyone for joining us. We hope you can join us next week when we have Dr. Peter Uhlhaas from the Charity University of Medicine in Berlin presenting on cognitive heterogeneity in the early phases of psychosis. Hope everyone is doing well, staying healthy, uh, hopefully getting better than gray weather than we are here in the Midwest. And Dr. Ruiz, thank you again for a wonderful presentation and for your time today.
Great. Thank you all for your time. Appreciate all the questions.
Bye, everyone.
Bye.